Hello, everyone. Welcome back to your favorite podcast. This is the Caring Neurologist with Dr. Sandeep Thakkar. We've been having amazing episodes. This is episode 12 already. And today we are going to go into gender issues. No, just kidding. But we will be talking about women and Parkinson's and what we've been missing because even though we totally advocate for women and men are the same, women and men are not the same when it comes to the body, right, Mr. Dr. Thakkar?
There are a lot of differences, and there's a lot of stigma that are different. So we are going to get into and deep dive into understanding a little bit more about those complexities.
Basically, what we're going to do is going to highlight the unique challenges that women face with Parkinson's diagnosis and treatment and progression. That's what we're going to be talking about today. I'm really excited and I'm going to dive right into it. Again, this is episode 12. If you have not heard our other episodes, you should go now and listen to all 11 of them. Otherwise, stay here. So, Dr. Thakkar, Parkinson's has often been studied and talked about as though it's the same for everyone, right? But women are telling us otherwise. So what do you see as the biggest gaps in how we understand Parkinson's in women?
Yeah, so whenever we're talking about the term of Parkinson's, there's always depictions of an older man walking, right? And it's usually this kind of older male that is depicted and historically has been depicted because a lot of this was James Parkinson's from 200 years ago, who even drew pictures of men that he saw in the park and saying like they all have these characteristics. And so it was really based on those type of characteristics and has been always thought that the predominance of symptoms have been, a resting tremor for a male and things like that. We do clinical studies that are predominantly male driven. And again, there's a lot of underrepresentation. So there are significant gaps that exist in our knowledge of Parkinson's disease because when we've done clinical studies, it's always been based on a lot of data and side effect profiles of 65 and older, typically men, and some of that proportion is like 40%, 35% women in these studies. I think that we're going to dive into how there's a gender difference in the disease state, but there's also ethnical changes that exist, and those are also important to understand, and that may be another topic of discussion. So for the gaps, we have to understand how hormones play a huge role. There's different symptoms that actually lead to different diagnosis, delayed diagnosis in women, and then how the management should be as time goes on. There's a difference in treatment response and side effect profiles because we don't change the medication specifically based on weight or body habitus for men or women. We kind of just have the standardized dosing. And then there's also different psychosocial quality of life differences that women deal with much more than men. And I think that from my day-to-day experience, we see it from even young women with young onset Parkinson's. It's a different disease than those that develop Parkinson's in women later in life. And that itself is its own gap, and understanding. So we're going to dive into the underrepresentation of research as well and clinical trials. But one thing I just want to make sure that why there's these gaps is because we don't understand the role of hormones, the estrogen, and how neuroprotective it can be. We know that estrogen has protective features the majority of a women's life, and how it also then affects how the response is through menstruation, changes in pregnancy, even menopause and postmenopause. Women have different outcomes and responses to typical levodopa therapies. And that's still not fully understood. So we need a lot of research to understand that and clarify those differences. And we'll even talk about the differences today about symptoms, which we typically would think of just motor symptoms, but women have to suffer a lot more non-motor symptoms.
Okay, let's eat this elephant by pieces. Let's start by the very beginning. Why are women often diagnosed later than men? this is a fact, right? Because I'm pretty sure it is. And is it because, as you said, the symptoms show up differently, or are they just dismissed more early?
Yeah, I was grappling with this kind of question, and as I was like reading through and then doing my own research as well, I think there's a difference here. I think, if a patient, by the way, when a patient comes into our clinic, men, women, it doesn't matter. When we look at someone that are coming into our clinic, it's a matter of like, they're our family, they're our responsibility. We don't look at it differently, but we still have to think about all these questions and the psychosocial aspects of it, because we ask about, their job, their current life, if they just retired, what is their family dynamics? Do they live in a 1-story home, 2-story home? So we actually, in our clinic, we are designed to look at it as gender neutral. It's about you as a person, right? And I think that when I look historically back at what happens with women in a diagnosis, there is this delayed diagnosis, but there's multiple factors. Number one is, do men first and foremost get diagnosed early? And are they in the clinic, first with the support of their spouse? Second of all, is there a difference in women and, the fact that maybe they're younger than their male spouses, for instance, and then they come in, males get all the attention, the care has always been focused on the male, and then we forget about what's going on with the spouse, right? And then women take on this caregiver duty. They do all this other aspects, and they're just tired, fatigued, and a lot of non-motor symptoms actually in women start off much more, and that maybe it is dismissed. But at the same time, do men pass away earlier? Do we see that women are dealing with a lot of grieving, a lot of other issues? Are they dismissive of their health and not coming in? It's really hard. There's a lot of historical bias that goes on. But at least in our clinic, I feel like women have been much more driven to take care of their health. At least that's what we see in Southern California. Also, they have a lot better access to healthcare than they used to in the past. So I think there's a difference in that. Women are typically more proactive as caregivers to help their male spouses, and they push men to get into clinical research, whereas maybe the opposite isn't there, right? The male care partner may not be as driven to get their their spouses, their partners into clinical research, because they're maybe more fearful about what research could do, how it could affect their wife, or their sister or their mother, or whatever it may be. We see that women don't get the same, due diligence to go and get into clinical research. So I think there's a lot of different factors that play a role in that. We also see that when women are presenting in clinic, there are actual data that says they are with less typical motor symptoms that are mistaken for other conditions. Now, when women come in, they may have more facial masking, they may have more restless limb syndrome, they may have pain, like in the shoulder. And those aren't things that are just easily to think of as, okay, it's Parkinson's. But at the same time, they may still have more tremor predominance. And these are things that, is it brushed off? Does it take longer for them to come in and get that diagnosed or worked up? Is it related to, again, the thyroid? So maybe there's a delay in all of these factors. And then women actually, they're dealing with maybe postmenopausal issues. And it affects already stress hormones, their sleep patterns. So we end up seeing that there's a lot of, again, is a delayed diagnosis based on other factors that women already have to deal with.
I was listening to you and I was thinking, and I don't know if this is a thing, but I think women, we are, I'm not going to say tougher, but we think we can handle anything. So, how there's a headache and we're like, no worries. We can, you guys, when you have a headache, you are like dead on the bed for 2 days. We're like, we just keep going. And maybe it's also our fault that we don't take the time to say, hey, I have to go to a doctor.
Yeah, I think that there's like, okay, for instance, when women get heart attacks, they're silent and deadly heart attacks. They're deadly because you don't get the clues that men get with the type of chest pain, the shearing pain. There's a lot of like these clues that aren't there. And we don't know how, again, those changes are and how they're represented. But again, there is data that says right now that the consequences, there are delayed diagnosis. It's longer delays for women to see a movement disorder specialist. And that's been looked up in the UK PD studies and surveys as well. There's a lot of differences. I mean, we see that historically with clinical studies all around the US, around Australia. I was looking at the research of it, and women are historically, like, they continue to be underrepresented in all forms of clinical studies. But when you look into Parkinson's, 4 out of 10 women are diagnosed with Parkinson's. Sorry, 4 out of 10 people that come into clinic are usually women that are diagnosed. And the prevalence of PD in women is, like, when we looked at the Australia studies, is 54% for women than men. And in the US, that's kind of the opposite. In Poland, it even seems that women are more diagnosed 1.2 times more than men. So there may be other situations that, again, the representation and the demographics are different, and we need to do a better job of early diagnosis.
When we began in your introduction, you were talking about hormones. And I guess hormones like estrogen, they do seem to play a role in Parkinson's risk and progression. So what is the science telling us now about that connection?
The science behind estrogen and how it plays a role, well, first and foremost, based on the current research, there's increasing evidence that estrogen, particularly 17-beta estradiol, plays protective roles in Parkinson's. So if we break it down and the connection of it, it's neuroprotective. Estrogen seems to protect against dopamine-producing neurons, which are those cells that, again, degenerate in Parkinson's. So when we've seen animal models as well, estrogen seems to be protective. It's protective. It's reducing dopamine neuron loss, and we've seen that in multiple models. We've seen that estrogen protects against toxins. So we do these models where we call it MPTP models, which are neurotoxins to destroy and go after dopamine neurons, and it seems that estrogen protects against that. Also, dopamine needs to be recycled or reuptaked. And we've seen that estrogen may interfere with that dopamine reuptake, which then helps keep dopamine levels more stable. And so that's why we may see some variability in different stages of one's life as a woman, especially postmenopausal. And then also estrogen can reduce oxidative stress, which contributes to neuronal or brain cell death, right? So it is an antioxidant itself. Now, when we look at even more details of the science, alpha-synuclein, we've talked about this in previous podcasts, but alpha-synuclein is the protein that is clumping up in the cells that is then spreading and creating this degradation of Parkinson's pathology, right? So what we know is there may be estrogen being preventive in allowing alpha-synuclein to clump together.
Okay, and you did mention this, but I want to have a specific space to talk about it, and it's the difference in symptoms presentation, like tremors versus stiffness, between male and female, like one by one.
One by one. All right. Well, it's going to be like there are symptom presentations that are different. Now, again, in my mind, when someone comes into a clinic and you think of the most recent male or female that came in, some of our patients, it's just so varied. And that's the other thing about Parkinson's. It's a disease of decades. So I may see someone in their 50s and 60s and 70s, and that they look very different within the disease state of someone getting in their 80s and 90s and living into their hundreds. So there's so much variability. But there was this young lady who came into my clinic just a couple weeks ago. She actually had symptoms as the age of 14. She was actually diagnosed with Parkinson's when she was 17. And she's in our clinic right now. She's in her early 30s. She has a child, and it's hard for her to manage all of these symptoms. And again, I was just thinking about how women present differently and how the different social burdens that are there to even be a mother and the dynamics of a relationship, right? And so Number one is the differences. They can be quite drastic, but there are some similarities. I just want to make sure that this doesn't mean that the differences are totally only for women, and this is always the case you'll see. But in women, they do have later onset of motor symptoms. So that means that they have more non-motor symptoms, a lot of pain, a lot of fatigue early on, a lot of sleep disturbances. That men typically will get more tremor early. Men would get more rigidity early on, and it's kind of obvious that they're slower, whereas women are more tremor predominant as their initial symptom. So women have more tremor early as far as their motor symptom, but there's a lot of non-motor issues that come about. Generally, these are benign, or they're not as troublesome in the beginning, but it gets worse as the disease progresses. So that's where, again, maybe hormones play a role as they get into more menopausal stages of the disease. But I think there's variability because we see with women, even during their menstrual cycle, they are worse for that week before the menstrual cycle, during, and then after they're better as far as their symptom response to medicines. Okay. So men don't go through these cycles. Men have a typical symptoms that are there all kind of through their course, but they present more rigidity type. They have more delayed development, as far as men are, as far as freezing of gait. Men don't get as much, dyskinetic movements like Michael J. Fox's twisting, turning. Women actually get that at a higher rate and higher, proportion, especially if they're thin and they're younger. As men get older with the disease state, they get more of this bent forward issue. Women get more of this drop in blood pressure, and they get these autonomic issues. So what we end up seeing in women is more non-motor symptoms. They are complaining of depression and anxiety more. They are exposed to these type of symptoms more so than men are. And it's not to say that men don't get the depression and anxiety, but you see this kind of changes as far as the perspective. Women would have more non-motor symptoms early on.
Dr. Thakkar, I do have to ask you, we have talked about the fact that Parkinson's is not an old person disease, that's not real, but 14 years old is when she started getting the symptoms?
Yeah. She had complaints of, muscle fatigue, coordination issues, and it was developing, like, I think by age 16 that there was tremors. And so, I'm sure that it was $1 million workup for what's going on. It must be a thyroid issue. And I know that she had told us that initially she thought it was fake, that it was, fibromyalgia, and it wasn't a real, and it wasn't actual symptomatology. So, this person missed out on school, delayed to go to college, end up getting her GED. These are things that, she knew something's wrong with her, and it was just really eating away at her.
But this is, I know you can get Parkinson's at any age, but I'm thinking this is unusual, that young.
Yeah. So this circumstance, again, a lot of this is that this form was a more genetic type of Parkinson's.
Okay. And you did, when you were talking about how difficult it was for her, or it is for her being a mother. So, let's talk about emotional and psychological impacts. Are these experienced differently by female patients? Are there different changes in mental health? You mentioned depression and anxiety. Okay, let's go there, and I'll ask you something later.
Sure. So when women diagnosed with Parkinson's, they experience unique emotional, psychological impacts alongside the physical manifestations of the condition. So the emotional, psychological changes we see, first and foremost, women tend to have higher rates of distress compared to men. We see that the mental health issues are likely to be more anxiety. You see a higher rate of apathy. There's a lot more fatigue. There's sleep disturbances that exist. And depression may be a little bit more resistant as time goes on. Negative impacts of self-image. The loss of femininity. We see that there's that struggle of that body image. Decreased sense of confidence is definitely something that we've seen in the research, as we've seen in our surveys and questionnaires. There's this feeling of being unattractive. So that leads to also social isolation. We see that there are difficulties with speech and communication that comes in with verbal fluency associated with Parkinson's disease. And so we see that women are much more socially withdrawn compared to men, actually. There's challenges that we see within the support structure as well. And that relationship issue of husband and wife is totally different when it comes to women being the one that is suffering with the disease state. Again, this is things that we've seen historically. And I see men, caregivers, care partners come in, and they're just fantastic. And again, I don't want to dismiss and to make it seem like there's this such divide that I'm seeing. I think there's these changes that are going on culturally and have been over the last 10 years. But I think there's still a lot of gaps that go along when women are diagnosed. We need to have a better understanding of the support system. But what we do end up seeing is women end up more likely to live alone or in nursing homes with this disease state. So there are concerns about the mental health and how it takes a toll physically.
Well, I was going to ask you about social support and caregiving roles, but it's pretty clear that for women, it gets tougher.
I think it really does. I think, we have to acknowledge that the stay-at-home mom, the realities of a working woman, it doesn't matter what that role of the woman is. They take on multiple hats, right? They have multiple tasks. Women can do things that men can do, if not sometimes better. Right? I mean, we see these things, but they juggle what goes on the social structure. And those are things that we don't take lightly, because when women are diagnosed, they still continue to do these things, right? I mean, cook, clean, make sure that everything's taken care of, maybe even finances for a lot of families. And, I just think there are differences. I mean, if we think about it, right, there are going to be differences, and we talk about like hormones and things like that are maybe different, but, there are young women who play soccer, who I'm seeing now, who may be exposed to pesticides. And if, you've seen our other episodes and podcasts, pesticides have a higher rate of developing and getting Parkinson's. Well, women are playing more sports now than ever before historically. And now they're going to be exposed to things that men are. And we're going to see that maybe there are some things that are different, not just also hormone based, but sports related. And so we may see differences at different times with the young onset female versus a late onset female on Parkinson's disease. Again, there are many times I've had patients in our clinic that are women in their late 20s and 30s that are debating about, should I tell my fiance about my disease state? Like, it's going to ruin our relationship. They won't want to get married, right? Like, how do I have kids? And so there is a different dynamic that goes on, and there's a lot of social burdens that women that face that men don't.
Actually, while you were talking, I was thinking, and I don't know, I may be overstepping, but I don't think a man would ever hesitate about telling his future wife that he's got Parkinson's, because it's a given that she's going to take care of him.
Yeah, it's very plausible. Very plausible. I think women may be more understanding about those situations. And again, these are the tough dynamics, these are really, really tough dynamics. I mean, if you're getting married to someone and you're in it for the long haul, I mean, I think you have to be clear with your intentions and your health issues. And, I think these are type of things that are really important to address ahead of time.
So let's talk about female representation in Parkinson's clinical trials. What's your take on the lack of female representation, and how does that? Yeah, go ahead.
Yeah, historically, it's been a lack of it. Sorry to interrupt you. I mean, there's a huge lack of representation in Parkinson's trials for women, and that's a concern because we have seen that when we look at data of how a medication works, it's been based on typically more associated with side effect profile or a benefit profile for men of certain body weight, and we're not taking into account the differences that women respond to in these medication studies, right? So when majority of the studies are including males, even though women are still part of it, we don't know we don't look into the sex differences of side effect profile. But what we end up seeing is women end up getting more side effects over time with dyskinesias, and that's, again, they may not need the same dosing. They may need 25% reduced, and that's what we're seeing, that there's a higher rate of complications of drop in blood pressure when patients or women getting the same type of medications that men would get. So we never account for the milligram dosage for weight, body mass, maybe changes in other bone density, and that may be association of muscle mass, right? So these are things that we should be accounting for. But what we end up noticing is that PD affects, again, men and women differently. The risk factors, obviously, as we study, is the cumulative estrogen exposure of women in that lifetime. It reduces Parkinson's disease. So we don't know still where hormone replacement therapy affects women later in the disease state. We need to understand that more. Women in Parkinson's experience those different ranges of motor symptoms and non-motor symptoms. And in our clinical trials, we're very specific about certain motor symptoms. We're always talking about on time and off time. And there are things that are secondary measures that we're looking into for non-motor, but it's still not a primary objective. And we're not detailing it more for women versus for men. The treatment response, again, is totally different. A lot of our understanding now is that actual women have different enzymes effectiveness. That's like, for instance, there's a COMT enzyme that we use to break down dopamine, and COMT, which breaks down dopamine in the blood and in the brain, is 25% less in women than it is in men. So that may explain a lot of reasons why patients may get more dyskinesias if you're a female. So there are those challenges that we still need to understand. And if we look into, just the disease progression, we should be looking at even women young onset versus middle age versus later in life. We should have a better understanding of how that's different in clinical research for them. So our research designs or recruitment need to be changed. There's a huge bias that exists already. And at least in our area, I was looking at the numbers. It was pretty even right now, where women come in just as men do. But I think that there are other logistical barriers that exist. Maybe it's that family responsibility that women have to still do. Being a mother, you're always a mother. And then even when you become in your 60s and mid 60s and 70s and 80s, you may still be helping out as a grandmother. And so there are those social constraints that I see that women may not go into clinical trials because it takes time and you have to keep following through in these studies. So there may be that burden as well that women continue to deal with socially.
I was thinking about two things. Number one is that there are drugs that women and men take. Say, I don't know, ibuprofen. You get a headache, you get that. But there are some drugs that are only for women, which is like contraceptive pills. And that should be studied, like the interaction between those kinds of drugs that are just for women and Parkinson's.
Mm-hmm. There should be. There really should be. And I think there's, like, because of AI and the way that data is being driven, we're getting more understanding of that. And I think that that's going to be the kind of evolution of, as we're doing the clinical studies, if something is protective potentially for one group versus another, like, we should be jumping on these aspects sooner than later.
And the other thing I was thinking about while you were talking about female representation in trials, I was thinking that there's no female representation whatsoever, because every time we think about a famous person with Parkinson's, it's always a man.
Well, yeah, historically we've seen the Muhammad Ali's of the world, right? The Michael J. Fox, that's what we think of. There's certain professional singers. There's that stigma that goes with Parkinson's. There may be issues that we're thinking about where maybe, again, women don't want to be letting others know. It's a private disease for them. Again, getting diagnosed is very different for each person and how they want to share the information, right? So again, we have Neil Diamond, who's a singer, and there's a reason why he's not going on tour. We don't talk about necessarily women and why they may not go out on tour to sing professionally, or why they're not acting. They could lose jobs. They don't want to necessarily say these things, that we have a diagnosis of such. So I think that these social ramifications we just need to understand better.
Okay, let's talk about a woman who's newly diagnosed. I do think I'm going to ask you whether there is like any specific conversations that she should be having with her doctor. But I'm thinking it's not the same to be diagnosed at 20 that at 40, 60, 80. So I'm guessing the conversation with the doctor would change.
Yeah. If I come across everyone at the same age with Parkinson's that comes to our clinic, it's probably a very similar conversation. But when we see young onset cases, male or female, we have to individualize it for what they're going through with their work schedule, what their career goals are, and how to manage the disease, and let them understand, like, we don't want to slow that momentum of them still chasing their career. The family social dynamics, again, we have to talk about. But again, with women, it goes into more details because they have more hats and roles that they play. So again, if a woman who was recently diagnosed with Parkinson's comes into a clinic, it's vital that she engage in an open and honest conversation with the doctor. You have to cover key aspects related to one's health. Okay, so when it comes to Parkinson's specifically, right, we need to understand the diagnosis, the disease state, how it's going to progress. We need to know more clinically about women and how it progresses. And so hopefully this is much more informative for others, but it is different. And so the treatment options, we may have to be utilizing lower amounts of medications. We need to be addressing the non-motor symptoms earlier. Maybe we should be not as hesitant to get a sleep study. Maybe we need to talk about the fatigue. Maybe we shouldn't just assume everything's just depression because of life and it's actually due to a dopamine state, but maybe there's serotonergic differences that we see. Serotonin, norepinephrine, these are other key neurotransmitters that we need to focus on more so with women, because they seem to have more blood pressure variability as well. And again, I think first and foremost is women probably need 25% less dopamine in general. So if we are giving them a higher amount, they're going to get higher side effects, which then lead to those aspects of weight loss as the disease progresses and the dyskinesias. So we have to create a more personalized treatment plan. Even more so when it's women who are younger and different stages of their career potentially. And again, we have to think of them differently, even postmenopausal, because again, bone structure, bone health. If a female were to fall and there's a bone density scan that shows that they're more brittle and osteopenia, then they're going to have a fracture. And now we're talking about complications of surgery, and we're talking about the rehab and being in a nursing home. So there's a lot of interplay. And as a clinician, when we're talking with females, we have to understand that interplay of menopause and Parkinson's symptoms, right? We have to understand that there's a fatigue factor that goes with it. There's higher rates of urine tract problems actually with menopause. We have to understand how we change our other dosing of medicines. Maybe we have to work as clinicians better, and as a neurologist, to say, I need to work with the primary care doctor. Or, are we dealing with our geriatrician differently? Do we need to see the endocrinologist more because we need hormone replacement therapy? There are things that are out there. Now, women also deal with hot flashes, which make sleep difficult, right? It affects mood changes. So we're seeing that maybe during this time, they're maybe more irritable. They're more isolated. Now, Parkinson's symptoms make that worse and exaggerated. So what comes first, right? The chicken or egg? Do we treat the Parkinson's components, or do we treat the hormone-related issues, or is it kind of like this combination? So that's also a very different discussion, but it needs to be discussed. And I think I tell this to all my patients, male or female, you've got to be your own advocate. You have to, right? And then we think about care planning, long-term care planning as a female. Advanced directives, having that support, getting your family members involved early, making sure about legal documents, living wills, healthcare proxies. This is important to get your care partners involved early and not have them feel quote unquote burdened later on when it's all drastically things are falling out of play. They should know, our spouses should know what's going on with our health. And so women need to be much more involved with having their spouses come to the clinic. I think that's a big part of it, that when a male is diagnosed with Parkinson's, it's like, okay, I need my wife here. I need my sister here. I need that support structure, and women need that support structure just as much.
What is that one step? What is that one step that we can all take as providers, advocates, or patients to move towards more gender-aware Parkinson's care? Doing this podcast, I think, is a very good thing, but what should we be doing?
Well, we have to be aware, again, that the diagnosis plays a different role in women. And I think that's just the first thing, is that hopefully this is understanding that men and women are extremely different when it comes to disease state. We have to first foster awareness of those gender norms and the biases. And we have to recognize that there are gender stereotypes with disease states. We have to understand that patients that are female experience and cope with this diagnosis very differently. I think about my patients that come in, especially some of my female patients, they're widowed. Like, they've lost their husbands, Men may die earlier and women have to live longer, maybe sometimes more isolated or alone. So we have to acknowledge also those aspects where that support is. And women have, they have this care burden. They're taking care of their maybe older male spouses, or the health related issues to their spouses that, for instance, we forget the psychosocial support that they need. So first and foremost, hormone influence, we need to understand how hormone therapy should be enacted early. We need to customize much more particular treatment plans for patients, whether they're, again, underweight, overweight. Right? We have to understand how the menstrual cycle plays a role. Maybe there's dose changes that need to be done during that time period. We have to understand pregnancy a little bit more, because women get diagnosed with Parkinson's, again, at a young age too. And there could be, again, genetic factors that make them get young onset Parkinson's. And now they have to deal with pregnancy. And how do we manage medicines and therapies accordingly? So there's that customizing of that. And then how menopause makes a difference for disease state and progression. So there's a lot of steps that need to be done. And then as we are empowering our patients, we need to enforce that patient-provider relationship, that women should feel that they're getting the appropriate, the appropriate kind of care that's needed. Now, what that means is, I've actually listened to a lot of other podcasts before we recorded today. I was actually listening to a lot of other health-related issues that women go through, and women do not feel heard. They do not feel like their health-related issues are actually understood, or that the doctors are not actually understanding what they're going through. So I want to make sure that when female comes into a clinic, you have your list of questions, you have your health-related concerns, and it's made sure that you got that right doctor with you, right? You feel like you're being heard. And again, we have to change as neurologists what we do and how we understand the non-motor symptoms of Parkinson's. And that's something that maybe, again, we're trained so much to think about tremor and stiffness and slowness, but we need to do better about sleep-related issues, depression and anxiety, understand how restless limb symptoms may be part of a Parkinson's state, but also more exaggerated with women. And then as we follow patients through, we may not just be using our normal scales to see how someone's improving. So we have to adjust for those as well.
I know we cannot change the world, but I do think this is our grain of sand to start talking about women and Parkinson's. And it's really important. And I personally, as a woman, want to thank you for going along with this and for wanting to talk about something that many people don't talk about.
Yeah, no, I'm glad that we get to touch upon these topics. There's going to be multiple topics that we're going to go through. And some are going to be extremely tough, and some are going to be fun, and some are going to be exciting. And, there's going to be discussions like this that we need to make sure that we are advocating now so that we are making changes for the future, because there could be something out there, again, as we are learning about estrogen and how, again, maybe even progesterone combination hormone replacement could be beneficial for women at different cycles of the disease state. But also, couldn't that open up for men? Couldn't we learn a lot that this could actually help the disease state as a whole? Are we thinking about maybe now we can use certain therapies that are disease modifying? So I think we're going to open up a lot of minds, and again, the clinical research that's out there. Hopefully there's avenues that are improving so we get those biases under control.
Dr. Thakkar, again, thank you very much. It's always very nice and enlightening to talk to you, and I cannot wait for episode 13.
All right, lucky number 13.